Good evening, everyone. So first of all, I'd like to thank Dr. Archana, ma'am. It's always a pleasure to come to SCPGI. And always feel nostalgia around here, and very happy to be here. So I'll be talking about a novel MR technique called MR fingerprinting, very recently introduced. Basically, the talk will be about what is MR fingerprinting, how it works, and what are the possible clinical implications and the future of the technology as well. So what is fingerprinting? It is basically what can be termed upon is the next kind of quantification technology, how you can do quantification in a better manner in MRI. So usually in MR, when we talk about MR imaging, we are talking about qualitative imaging. So we are basically seeing certain images. We are qualitatively assessing certain properties of the image. And based on that, basically we are making a diagnosis on that part. So a typical MR image basically is a mixture or a composite of different weighted tissue properties. And that's the important part. What we are talking about is usual qualitative MR images are basically weighted images. So when we talk about T2, T1, or so on, those are basically not exactly the T2s and the T1s. And then you can do quantification. You can get the absolute values, but you will need alternate methods for that part. Then basically the robustness of the quantification, what you can get, or even the qualitative part, these are highly dependent on the system parameters. That means there is a possibility of large amount of variations in the data, and that can impact your outcome, clinical outcome as well. So we are talking about basically the qualitative imaging part. So quantification, we know is very important, and it can help us in differentiating healthy versus the unhealthy tissue. And basically it can help you in getting better diagnosis. It can give you an idea about the prognosis and the therapy outcomes as well. And then basically it enables the objective comparisons of different time point studies as well. So qualitative imaging, the quantitative imaging forms an important part specifically when you want to be certain in diagnosis as well as the disease progression aspects. So quantitative imaging help you in getting better diagnosis, therapy response, and the follow-up studies as well. We know that the quantitative imaging is the quantitative part in our clinical life is very important. We already have a lot of quantitative parameters available with us, where you can get exact cutoffs of normal versus abnormal, as well as in some scenarios, grading of the disease as well. In MR also, there have been methodologies available. There are methodologies that are available that talks about quantitative measure rather than the qualitative measures, like relaxometry measurements across anatomies, brain, cardiac, liver, cartilage, and fat quantification for liver. All those things are already available. But the issue with these type of quantification is the robustness. How much you can trust the data or the values that you are getting from your scanner. And that is purely because how you are getting that quantification done can be having a lot of variations in that. So like this image shows T2 image from different qualitative aspects. So you can see the image looks different. All are T2 weighted images, but all are giving different visual interpretation or different visual impressions, I would say. And that is because your hardware is not perfect. The environment where your machine is installed is not perfect. And there is a possibility when you are taking references from literature, the variation in your machine, be it a same model from a same vendor, it is possible to have variations that are large enough to give you false impressions or not giving you the accurate values, to trust the already available data from literature. And this has been the problem in quantitative MR for a very long time. So, I mean, you can get basically a lot of artifact that can be very site specific. that can be a model-specific phenomena. Then there can be intermittent issues in terms of your coil miscalibrations and so on. So fingerprinting can basically give you a lot more robust quantitative data, and it can address a lot of these challenges as well. So what is fingerprinting? Rather than a regular MR imaging, where we are acquiring data and the data is converted into image, and then we are using certain methods to get some quantitative maps. Here we are not collecting images and then interpreting the outcome or the quantitative part. Rather than that, we are collecting information from the data acquired, and that information is used for the quantitative assessment. So fingerprinting is based on three basic aspects. The first part is a specialized pulse sequence, which is a rapid acquisition where there is a time varying parameters. Different parameters are randomly basically acquired, and these are fluctuating when the acquisition is happening. So that's how a normal fingerprinting acquisition looks like, and that's how it sounds. As I said, it is not like getting images, getting information. So the video, what you saw probably doesn't give you a very good impression about fingerprinting, because we are used to getting the qualitative assumptions of the images as well. So what we are getting is basically it's a pseudo-random excitation and spiral readout acquisition, and then during the acquisition, rapidly parameters like T, TR, FA, and the readout are changing at the same time. So that basically enables the outcome to be more robust in certain terms. And then it also reduces the scan time significantly, considering what the outcome you are getting out of the fingerprint data. Then it also basically corrects for one important implication in your routine MR imaging, that is motion. So that is also taken care of using the fingerprinting scheme. So what we are getting is, on the left side, you can see this is what you are getting, the data. And then each data, in each pixel, you have a specific pattern depending upon the tissue and the fingerprinting scheme used. It can give you a specific pattern of signal signal coming from that particular pixel. Now, the second step of fingerprinting after acquiring this data is basically matching of that matching of that pattern, this signal pattern, with an already available dictionary. Now, this dictionary is basically calculated. It is not basically quantified using image-based methods. So these are basically simulation-based calculations done by algorithms, where you know the spin patterns, and algorithm basically defines thousands of possible combination of your relaxometry data. That is your T2 and T1 relaxation part. So what you are getting, we know that in MR, we are talking about primarily a T1 and T2 relaxation. So T1 values, T2 values, and then a fixed MRF sequence, which can be different type. There are a lot of fingerprinting based schemes available in academic domain. And then basically using a fingerprint based simulation, we are generating a dictionary, and then basically each pixel of the data that you have collected is matched by using a pattern recognition algorithm with the data is matched with that dictionary that is already available with the scanner or with you. And then when there is a 100% match of your combination of T1 and T2 values, then one pixel of your quantitative imaging map is created using the fingerprinting dictionary. So this is how it looks like. There can be thousands of possible combination of T1 and T2 based on your tissue type. and also based on your fingerprinting scheme. When the data is absolutely matched, which is already there in dictionary, remember it is not dependent on your system imperfections or type of scanner, because it is calculated by already available algorithm. It's a simulation based calculation. And then this is how it looks like. There can be thousands of possible combination of T1 and T2 with increments of your relaxation times. And then we are matching it. And then basically you are generating a dictionary. That's how it looks like. Several possible combination of T1 and T2 relaxation times. And then each pixel is generated for your map. And what you are getting is a very, very robust quantitative maps, which are free from system imperfections, inter-site variabilities and all, and also corrects for a lot of artifacts as well in the background, because the acquisition scheme is such that. So in summary, we have a specific pulse sequence. Then the data is matched with already available dictionary in the system. And then a quantitative map, which is very, very robust, is generated. And for each pixel, you are getting both T1 and T2 map simultaneously, rather than generating based on the different echo times or different IR values in case of T1. So you are getting that. So this is how it looks like. Right now, commercially available fingerprint acquisition gives you T1 and T2 quantification. But there are a lot of algorithms available. There are a lot of MRF schemes available in research domain that can give you more parameters than T1 and T2, and also in more anatomies. Right now, it is available only for brain and gives you T1 and T2, which is commercially available. So as I said, more parameters can be added into a fingerprinting scheme, like you can get perfusion values as well as the ADC values from specific fingerprinting schemes as well. Just to give you an idea, clinically, what it can do, there is a interpretation software available on the scanners. And this image basically shows a tumor patient, a brain tumor patient. And the color of the RY represents basically the values in terms of T1 and T2 relaxation. And you can see that it is able to differentiate among the tissue type using the combination of T1 and T2 values. So if a ROI is placed in a cellular part of the tumor versus a necrotic part versus a tumor adjacent part with some edema, or versus a normal appearing ipsilateral and contralateral type, it is able to distinguish among the tissues as well. There have been a lot of work done by different universities and research scholars, and this is one such study where the quantified MRF parameters of T1, T2 gray matter fraction, as well as the relative M0. Basically, it was able to show that in T1 map, the fingerprinting based T1 map was able to locate an abnormality where your regular, routinely clinically available 3D T1 weighted image, it was apparently normal. Similarly, in the same study by Ma et al., they have demonstrated, like in this case, in periventricular nodular heterotopia, you can see here fingerprinting based T1 map was able to locate the abnormality. The laser ablation was done for the patient, and the patient was seizure free after 5 months after the treatment. So there have been instances where fingerprinting showed that you can get more out of your clinical domain than routine imaging using fingerprinting in epilepsy. Similarly, a lot of pathologies, it has been shown to be useful as well. As I said, commercially, as of now, it is available only for brain, but in academic circles and research domain, it is available for different anatomies as well. One such publication talk about basically use of fingerprinting in prostate. Dr. Chatterjee talked about the combination of T2 and ADC value in the model that they have generated. And similarly here, you can see In this particular case study, peripheral zone and transitional zone were basically assessed using fingerprinting and along with the ADC values. And prostate cancer, you can see AUC values were found. I mean, the fingerprinting-based scheme was possible to get very good AUC values and to differentiate between prostate cancer versus normal peripheral zone. It has a very good correlation in differentiating high and intermediate grade versus low grade cancer as well, and prostatitis versus normal peripheral zone as well. In transition zone, it was found that the combination of ADC and T2 to differentiate between prostate cancer versus normal transition zone, whereas ADC and T1 values combination was found to be effective in differentiating between high or intermediate grade versus the low grade cancer. So it has been there for some time now, developed by Case Western University specifically, and now being used at multiple locations, this particular software. Now it has been, I mean, I talked about the robustness part, and that is where the fingerprinting scores over the conventional quantitative measures. And it has been tested several ways to check the reproducibility of the technique. And there was one study where they basically studied using NIST phantoms for different time point at the same scanner, same place. So it was found to be very reproducible. Similarly, it is tested along different scanners. And then again, the similarity between the data generated, again using NIST phantom, was correlating significantly. And there was a very little variation among the different scanners using the same technique. And then same patients were tested along different scanners, the patient data rather than the phantom data. And again, you can see the variation was found to be very low. In case of T1, it was less than 5%. In case of T2, it went up to 8%, but less than 8% in all scenarios. So it was found to be very robust, highly reproducible, and that's what you're looking for a quantitative measure in any technique. So as I said, it was developed initially by Case Western University, has been used by various universities like Medical University of Vienna, and Essen University Hospital. It has been tested and used and found to be very robust. And there have been a lot of literature available on fingerprinting that you can look at. So overall, there is a MRF clinical research community which is developing new fingerprinting scheme where you can get more parameters rather than just T2 and T1, and also across anatomies. I mean, these communities are generating a lot of scientific evidences, and then it is possible in future to have a pathology translator kind of AI-based, I would say, evaluation algorithm where you can put, rather than just a T2, T1, MRF-based different parameters and maybe some other parameters like perfusion and all. And when you have 4 and 5 parameters where you can use, rather than a qualitative permutation and combination, what we are currently doing, rather than that, we can have quantitative 4 or 5 parameters. And by use of AI, we can, as Chatterjee also showed, based on 2 parameters, he was able to predict a lot of high clinical outcome. It is possible to get much more insights in therapy decisions, follow-up, and patient prognosis as well. So that's it from me. Thank you for your attention. Any questions, I'll be happy to answer.